And so let's talk about shoulder dislocation. How do you know your shoulder's dislocated?
It
hurts like hell,
It hurts
right?
like hell.
All right.
You can usually see a deformity, have trouble raising your arm. Some people, sometimes when they dislocate, they'll spontaneously reduce. I actually see quite a few people who have that.
They'll pop out and then pop in.
Yeah.
Okay.
But then other people have to come to the emergency room and have it put, reduced under or put back in under some anesthetic. We drift them off to sleep so we can get it to go back in, and then we have to deal with the sequelae of that. For older folks, when that happens, a lot of times they don't continue to dislocate. Essentially, the younger you are when it happens, the more likely you are to have repeat dislocations. Each decade, as you get older, it's much less likely you're going to have repeat dislocations. More likely that you'll have, in conjunction with the dislocation, a rotator cuff tear. So we'll often see that if we have a 70-year-old or 80-year-old who has a fall and a dislocation. The ball, the humeral head may spontaneously reduce, or we put it back in, but then we find that they have rotator cuff tearing. So it's the pathology changes in young people. It's an issue, injury to the labrum and the capsule. Sometimes you start to lose bone. And that makes it more complicated.
Seems to me when that ball comes out, it's got to tear something.
Yeah. And I deal, I don't deal as much in the younger population. A lot of my sports medicine partners treat instability. For me, a lot of times when people are older, we see folks who have had chronic dislocations. Their shoulder's been dislocated for months.
It stays dislocated.
Right. And then we're talking about shoulder replacement. So it's a broad spectrum, and a lot of it has to do with how old you are. If you're younger, you have repeat dislocations. Well, surgery is on the table to determine what needs to be repaired, and there's various surgeries to take care of that problem, and a lot of it has to do with how many times you've dislocated, what activities you're involved in. If you're an athlete, you play football. I'm
thinking about this young wrestler, very talented young wrestler, but keeps dislocating. Could there be a surgery to tighten it up and make it less prone?
Yeah. So the first line of treatment is usually repair the labrum that's torn, repair the capsule, see if that's going to.
So that you can do that.
Yeah, absolutely. That's I would say the majority. That's the solution. But for people who keep dislocating or start to lose bone on the socket, then you have to get to more involved procedures to provide stability, and especially in people who are involved in violent sports, sometimes you have to go to that more extreme measure. Where we're doing actual transfers of bone in the shoulder to help with stability. So, so
that sounds complicated.
It is. And a lot of my sports medicine partners, that's, a lot of what they do when it comes to shoulder surgery, in addition to rotator cuff.
They do it too.
Oh, yeah.
So it's not just Kurt doing the shoulder. The other surgeons are very qualified as well.
Yeah. All of my sports medicine partners do a great job with instability and the other issues that I treat, like the rotator cuff tears.
Okay, now I don't want to give specific medical advice, but you got to tell me. You're out. You're miles from home. You're out in the middle of nowhere. Your buddy dislocates his shoulder. What is the move? Is it external rotate, pull down? What is the stereotypical move to pop it back in?
Yeah, when I reduce the shoulder, it helps if you have someone giving you resistance from the other side of the body, whether it's with a
all right. So we got three guys now in the middle of nowhere.
You have the injured person, and then if you have another person, that's helpful. But a lot of times it's traction, pulling down on the arm with gentle internal and external rotation.
Okay, rotate a little bit,
and then I'll actually try to find the humeral head that's prominent here. And
it's here.
Oh yeah. So it's. Most of the dislocations.
It goes forward. Yeah. Oh, I thought it would go down this way.
Most of them are anterior. Posterior dislocations occur in seizures, and people get electrocuted. So things like that will make it dislocate posteriorly. So the vast majority are anterior. So you're able to typically feel where that humeral head is.
Okay.
Traction, some gentle internal and external rotation, and usually a little bit of manipulation.
And push that sucker back in.
Yeah.
That can be done.
There's lots of different, historically, lots of different ways that people do it, and that's just how I do it. But
So it's going forward here. This is the subscap. So this is the collarbone here. So it would go this way.
Nestled underneath there, yeah.
Okay. All right. Don't do this at home. I just wanted to know.
Yeah.
Asking for a friend.
Definitely would give it a try in the wilderness.
Yeah.
And if not, then pat him on the back and hike it out to wherever you got to go to
right.
get some sedation.
Gotcha.